right, well, why don't we go ahead and get started. Thank you, everyone, for joining us today. My name is Michelle Proser. I'm the Director of Research at the National Association of Community Health Centers. NAC has been partnering with the Association of Asian Pacific Community Health Organizations and the Oregon Primary Care Association to be the national team behind PRAPARE. This webinar comes out of an effort that brought together national, state, and local partners who have been working collaboratively over the last year to plan for a California-wide PRAPARE implementation strategy in a way that supports health centers' population health and organizational or community health transformational goals. We've had the privilege of working with the California Primary Care Association, Alameda Health Consortia, the Community Clinic Association of Los Angeles County, Redwood Health Community Coalition, and the health center partners in Southern California, as well as 8 PRAPARE pioneers, 8 different health centers across the state of California. So today you'll be hearing on-the-ground experiences from 2 California pioneers, those implementers with key insights to share in implementing, adopting, and using PRAPARE. Please note, though, that PRAPARE implementation is still pretty new for most health centers, including the pioneers. So what you'll hear are the early insights, best practices, and lessons learned that can inform others as they plan for PRAPARE implementation and use. Currently, there are around 100 different organizations, health centers, and other providers currently using PRAPARE in the state of California. Before we begin, I have one quick housekeeping note. Given the number of people on this webinar, which we're very excited about, we've put everybody's line on mute. We will take questions at the end, but encourage you to use the Q&A function or the chat function to ask questions, and you can find those functions on the right of your screen, either at the top or the bottom. This webinar and our entire California PRAPARE planning effort was made possible with the generous support of the Blue Shield of California Foundation. The Blue Shield of California Foundation was also one of the original foundation supporters behind the development of the PRAPARE tool nationally. So today we'll quickly cover a couple of things. We'll hear from our longtime partner at the Blue Shield of California Foundation, Rachael Wick. We'll provide a quick overview of PRAPARE. We'll hear about PRAPARE experiences and the impact it's having at 2 health centers that are part of our planning grant, so 2 health center pioneers in the state of California. We'll hear from Selena Chan and Maria Reyes at La Clinica de la Raza, as well as Corinne Knudsen at La Maestra. And then we'll hear briefly from the California Primary Care Association's Dal Sheehan about bringing PRAPARE to scale across the state. And then we want to leave time open for Q&A, as I mentioned. So with that, let me turn to Rachael Wick, Senior Program Officer at the Blue Shield of California Foundation.
Thank you, Michelle. Good afternoon, everyone. I'm Rachael Wick, Senior Program Officer at Blue Shield of California Foundation. I want to welcome you all and thank you for joining us today to learn about our efforts to test PRAPARE here in California. It's the Blue Shield of California Foundation's mission to improve the lives of all Californians. And as you probably know, we've worked to improve access to care and reduce the uninsurance rate here in California. But we know that that's just part of the equation when it comes to getting people healthy. Health is about so much more than just health care. We know that 80% of our health is determined by factors that exist outside of the healthcare system. Experiences of trauma, housing instability, community violence, and economic inequality are some of those factors. Only when we understand how root causes affect patients' health and their lives more broadly can we address the unique barriers to health facing patients and communities. From its earliest days, the community health center movement has been about more than providing health care. And in this moment, it's perhaps more critical than ever to recognize and account for the stressors and influencers that are impacting people's health and wellness. I can't emphasize enough that collecting standardized data on patient social determinants of health is really foundational and should be a precursor to any action that health centers want to take to address these social and economic needs. It's one of the reasons we were early funders of this project. Many of you know the challenges intuitively, but PRAPARE offers a structure, processes, and systems that will support you in doing this work in a systematic way. It can build awareness, intention, and action, both within and outside the walls of your health center. Our early learnings in PRAPARE suggest that when health centers implement it, it can improve provider and patient engagement. It leads to more compassionate care, effective and efficient care, care that we think is higher value. And if we can collect standardized data and aggregate it across health centers in a community and actually across the state, it has the power to inform how we might address needs across health centers across the community and in partnership with community-based organizations to advocate for really big social change. I want to close by thanking the awesome group of local, state, and national health center leaders that have been part of this effort and who will be sharing their stories with you today. They have been hard at work collecting the data and testing different workflows, and you'll hear more about that. Their experiences of these pioneers, as Michelle said, will be instrumental in helping us shape a strategy to bring PRAPARE to scale here in California. So it's really, our goal is to get to a place where every health center would be using PRAPARE to collect data and take action on patient needs. And I want to close by inviting all of you to be partners with us in that and hopefully applying the learnings and the tools that you're going to hear about today. And I know the team is going to send a short evaluation after the webinar where you'll have an opportunity to tell us what you need to do this work and to do it well. So again, thank you so much for joining us today. I'm excited to get started, and I'll turn it back to Michelle.
Thank you, Rachel. So with that, we are going to move into a very brief overview of PRAPARE. So the protocol for responding to and assessing patients' assets, risks, and experiences, or PRAPARE, is really designed to be a standardized protocol to engage patients in assessing and addressing social determinants of health. As I mentioned earlier, the PRAPARE tool was developed by NAC, APCHO, and OPCA, as well as the Institute for Alternative Futures. I want to emphasize here, though, a couple of things. One is the word standardized. We believe that standardized data is foundational for developing new social risk interventions and for developing new partnerships in the community, as well as to better manage and empower patients experiencing these risks. It's also really critical to collectively document the impact SDH, the social risks, are having on outcomes and costs, as well as for finding ways to sustain an integrated, value-driven delivery system that can diminish those upstream risks. I also want to talk about PRAPARE as a protocol. PRAPARE was meant to be more than just a screening tool, so we've paired it with an implementation action process. The implementation action process has been packaged as a toolkit on our website, which I will highlight later. PRAPARE was designed after conducting a very broad scan of existing screening tools, trying to find those that really seem to work best for health centers. After doing that, we really felt it was on us to find a way to balance validated screening tools with what we know works in a community health center setting. So to get that balance between validated and vetted, we also engaged in an effort to solicit feedback from health center staff and patients. We also reviewed the literature and national social determinant health initiatives or coding structures to make sure that we were aligned with those initiatives or coding systems. So, for example, we looked at Healthy People 2020. We looked at the ICD-10 codes around social risks or non-clinical risks. We also tracked the Institute for Medicine's recommendations on social risk factors that need to be included in the meaningful use, the final stage. I want to talk briefly about the design and as well as some of the experiences to date so far. So one of the things we knew early on is to make PRAPARE most clinically useful, it had to be integrated into the EHR. So we developed PRAPARE into 4 different EHRs that are commonly used across health centers. I'll talk about those soon. and we're working to expand those templates. We also wanted to make sure that it could be implemented in a variety of settings and workflows using current staff. And of course, we wanted to make sure that the data collected from PRAPARE can really be actionable at both the patient or point of service care and the population levels. And as Rachel said and mentioned, we found that PRAPARE builds trust among patients and providers. It really identifies new needs, so documents the extent of existing needs. And we're also seeing that it leads to positive changes at the patient, health center, and population levels. So some examples of our earliest PRAPARE pioneers, they've been using PRAPARE data to build new partnerships with local community services. For example, a health center in Iowa knew they had a transportation issue because they were running out of bus or taxi tokens or vouchers early each month, but having PRAPARE data where they were able to document the extent to which patients really had transportation barriers to care. Using that data, they then worked with the local transportation authority and are now working on new bus routes to make sure patients can get to care. Health centers have been using it to expand enabling services, streamline care management services. Many said they use it to better match prescription or treatment plans with patient circumstances. So for example, if a patient does not have stable housing or has issues with utilities, to make sure that patients' prescriptions do not need to be medicated. Some health centers are also using the data to experiment with patient segmentation or risk scores. And others are also using it to inform delivery system redesign. So for example, in developing partnerships through accountable care organizations. We also wanted the PRAPARE tool in design not to be a research study, but to still be standardized. So when we say standardized, we're talking about standardizing the risk, not the way the question is asked. So part of our implementation packet includes ways to use this as a patient engagement process through talk story, motivational interviewing, empathic inquiry, and other approaches, so you can really build that trust and document risk at the same time. So in other words, PRAPARE is also a conversation starter and designed in a very patient-centered approach. PRAPARE implementers are also able to make the questions more granular if they need to, and add questions or use it in combination with other tools. PRAPARE was also designed to be a tool that can screen all patients, but many are actually applying it to specific populations, at least to start. I won't go into the next slide in detail. There's a lot of information in our toolkit, but I just want to point out again that PRAPARE was designed to be implemented in a variety of settings in a way that made sense for each health center. So health centers really made a decision around, did it make sense for them to use clinical staff like MAs, or non-clinical staff such as community health workers or patient navigators, patient care coordinators. And they had their various rationales. Some liked aligning it with the clinical care model. Others really wanted to make sure that the person screening was also the same person who could be available to respond to identify risk. We're also exploring IT-enabled strategies to help bring it to scale across more patients. So for example, patient portals and iPads. But as you can see, the decision of how to implement varies by health center, and it depends on staff model, workflow, and it even depends on space. In our early pilot with our first 7 health centers, we found that there are unique needs across health centers, so those needs do vary. But when you look at how common risks are, we wanted to look at how many social risks do patients typically experience, and we found that patients typically experience between 4 and 7. However, the health center that's serving predominantly chronically ill patients, at least in this in their starting population, so the health center that had a sample population that had a higher burden of chronic illness actually found that those chronically ill patients had even more. They had between 9 and 11 social risk factors on average. Taking this data, we were then able to tell that the more social risk factors a patient had, the more likely that patient was to have hypertension. As I mentioned, PRAPARE has been used in a variety of different ways, and I talked about some of those already, but they have been used at the individual population, and we're seeing it being used at the policy and delivery system level as well. The templates are currently available in NextGen, eClinicalWorks, GE Centricity, and Epic, and those are among the more commonly used EHRs across health centers nationally. We're also working with a variety of other partners to build it into other templates. Our PRAPARE Implementation Action Toolkit, as well as our website, has a variety of resources to guide the process, as well as to really explain and highlight some other health center experiences so far. So our Implementation and Action Toolkit really covers the strategic implementation process, stakeholder engagement, moves on to the technical staffing implementation, covers data capture and data use, and then also has several chapters on how to actually respond to needs. Also on our website, you can find PRAPARE in Spanish and Mandarin, and other languages are coming, frequently asked questions, and webinars from previous demonstrations. I've already mentioned this, so I won't go into detail, but we've been very fortunate over the last year to be working with a variety of partners across the state of California to really figure out the best process to accelerate PRAPARE implementation and to make sure that the implementation of it leads to delivery system redesign across the state of California. And we've been pleased to work with 8 health centers in this planning grant as well. So with that, let me turn to the first health center who you'll be hearing from today. So let me open it up for Maria Reyes and Selena Chan from La Clinica.
Hi, good afternoon, everyone. This is Selena Chan from La Clinica. I will be co-presenting today with my colleague, Maria Reyes, who's the Community Health Education Manager. I'm part of our planning department here at La Clinica. I'll give you a quick overview of our organization. We are a federally qualified health center with 34 sites in 3 counties in the San Francisco Bay Area. A little bit about our patients is that we predominantly serve Latino patients who are non-English speaking. We also serve African American patients and Asian patients as well. And most of our patients live below the federal poverty level. A little bit about the Community Health Education Department. The staff are the ones who primarily administered PRAPARE for the NAC pilot. And the Community Health Education Department is made up of health educators and promotoras who are really involved in educational work at the community level. And some of the programs that they're currently involved with tackle healthy eating and healthy and safe environments. So social determinants of health have been really integral to the work of La Clinica ever since La Clinica was founded more than 40 years ago. We've been really rooted in the community that we serve since we're based in the community, and we were founded due to the lack of healthcare services here in the Fruitvale district of Oakland, which is a predominantly Latino neighborhood. La Clinica also has an agency-wide continuous quality improvement committee. It's made up of every department in the organization, including clinical and support departments. And we talk about how to advance quality improvement goals throughout the agency. And each year, CQI identifies a special initiative to work on. And in 2016, we decided to start working on social determinants of health. And at that point in time, we wanted to figure out a way to identify social determinants of health indicators amongst our patient population and then figure out which measures to track. And then in 2017, we heard about PRAPARE, and we then got involved in the NAC pilot, which is what we're going to share more about today. And due to this special initiative, we formed a social determinants of health subcommittee in our agency, which has very diverse representation and leadership support. So the members of the committee include members of our IT department, members of our medical department, community health education, and then the planning department. And I just wanted to highlight some of the other types of social determinants of health work that we're currently involved with. We have a transitions clinic in Solano County at one of our sites that provides very comprehensive services to the reentry population. And then another example is that we have a legal clinic at one of our school-based health centers.
Hello.
I'm going to pass it over to Maria.
Thanks, Selena. Good afternoon. This is Maria Reyes. I provide support and oversee the Community Health Education Department at La Clinica. And our department was, thanks to the support of NAC, we were able to implement the PRAPARE pilot project at our agency. And through this effort, between April 1st to September 31st, we were able to collect 412 questionnaires. And they were primarily implemented in a non-clinical setting. And I can talk a little bit about on the details on the next slide. So for our community health educator, a bulk of our work currently is doing education and outreach around healthcare coverage for Medi-Cal and Cover California. Our staff are certified as enrollment counselors, so they are able to go out to the community to inform patients and community members, but also are able to enroll them into coverage. So one of the approaches was to have our community health educators implement PRAPARE during their enrollment appointments when they had patients of La Clinica. One of the challenges was that because they not only see patients, they also see community members, the pool of patients was limited. So we had to come up with various strategies to be able to reach our goal. So another strategy that we implemented was to have our staff go to the medical and dental waiting rooms where they work with patients as they waited to be seen, and they implemented the questionnaire that way. Some of the challenges in that particular setting at times could be the space, or also finding private space for the patient to feel comfortable having a conversation with our staff. The next strategy was through our patient navigator program. We have a staff who is located at the emergency room at Sutter Hospital in Vallejo, and we had her implement PRAPARE with patients as they were discharged from the ED. What we find is that it was a bit challenging because in this particular setting and with the population, in many instances, the patient didn't feel as well to be able to focus and take the time to answer the questionnaire. So it was one of the areas where we ended up yielding less numbers than expected. And we also came up to the conclusion that it's probably not the best setting to implement PRAPARE. The other approach, as Selena mentioned, we have our Transitions Clinic project in which a community health worker is providing case management and linking reentry population patients into various resources. So she actually utilizes PRAPARE as her main intake tool to be able to assess the needs of this population and eventually link them to various resources in the community. We also piloted doing phone calls to patients from our Contra Costa Cares patient list. This is a program in Contra Costa County that has provided resources for uninsured community members who are not eligible for Medi-Cal. And we have this list that we were able to utilize to contact the patients and provide or do the questionnaire over the phone. Finally, the last strategy was through our Joint Ventures Health Nurses Program. These are master level interns, nurses that are doing an intern at La Clinica, whose main role was to conduct home visits. And they would conduct home visits to patients with complex conditions. And one of the challenges with this particular strategy is that the students were not as familiar with local resources in the community, so they felt that they were not as prepared to be able to link patients to the resources needed. Let's see, going to the next slide. So what we, as a result of this project, we identified a couple of needs. We noticed that some of the areas that were most prevalent in terms of that were highlighted in our questionnaire was the need for access to enrollment services, CalFresh in particular, Medi-Cal, also access to food, mental health services, particularly under the current administration. There seems to be a high stress level and anxiety among many of the patients we serve. We do live in the Bay Area, so housing, it's a Bay Area-wide issue in terms of having affordable housing and stable housing was one of the top areas identified. Transportation, to be able to access services and go to medical appointments, and also the need to access immigration and legal resources. And because of that, we felt that there was a need for La Clinica to come up with a system in place in which we could have a database or a directory that our staff and our not only in community health education, but in the clinical departments who could access those resources to be able to link patients to services. So some of our the partner organizations that we have been working with to either link patients and community members to services or to collaborate in this effort is CPCA, also our local community clinic consortium, who have been instrumental in training our staff on information about coverage and enrollment. We have funders that have gained interest in helping La Clinica sustain the data collection for PRAPARE. Also, we work closely with local community resources such as day labor programs, Head Start and First Five Center, and also county services, as well as our school district. And we do have also strong collaboration with Centro Legal de la Raza, which provides immigration services, and also the Jewish Family and Community Services of the East Bay, who come to our site twice a month to provide free immigration consultations to patients and community members. We also collaborate with churches and food bank to refer community members to those resources. And the food bank actually comes to 2 of our sites twice a month to distribute free produce to patients and community members who can benefit from it. Also, our county mental health services and our local transportation company, who we work with closely to obtain bus passes so that we could provide those to our patients that need to access transportation for medical appointments or to access resources or medications.
Okay, I'll highlight some of our data findings from the NAC pilot. Again, we collected 412 PRAPARE assessments, and I'm just going to highlight some of the findings that we found that were interesting. First, in terms of the gender of PRAPARE respondents, 2/3 of our respondents were female, and then 1/3 were male. And then we found that 75% of the respondents preferred a language other than English, and this was predominantly Spanish, and then 1/4 of our patients preferred English. And so we ended up using the paper form for Spanish more than the English version. In terms of housing, Maria highlighted this earlier, but we wanted to show the data for housing insecurity. So on the left, one of the questions asks, what is your housing situation today? And about 90% of those who responded to PRAPARE have housing, but among those who do have housing, around 25% are worried about losing their housing. And this is something that we've heard a lot amongst our patient population. Housing insecurity is a major issue, especially in the Bay Area. On the left, the question that was asked is, what is the highest level of school that you have completed? This is looking at educational attainment. So around 1/3 of our patients who responded to PRAPARE don't have a high school degree, and then 43% have a high school diploma or GED. So the majority of the patients who responded to PRAPARE don't have high levels of educational attainment. And then on the right, the question was, what is your current work situation? And around 19% are unemployed and currently seeking work. From our PRAPARE findings, we saw that there were a lot of patients who aren't employed currently and not seeking work. And in talking to staff, the reason why around a quarter of the respondents are not seeking work is because a large majority of them are stay-at-home moms, and some of them are on disability. And then this question addresses material security. So in the past year, have you or any of your family members you live with been unable to get any of the following? And they were able to select multiple options. And from this question, we saw that the major concerns amongst those who responded to PRAPARE were food, clothing, and utilities, as well as medicine or healthcare. And we got feedback from some of the folks here at La Clinica when we shared the data, and they were interested in exploring this further in terms of what does it mean that folks are unable to get medicine or healthcare because they're seeing us here in the clinic right now. And so we're curious to see if this is actually access to healthcare or for paying for services. In terms of sharing some of the PRAPARE data, we have been having monthly social terms of health subcommittee meetings where we talk about what the implementation process for PRAPARE has been like, and we troubleshoot and talk about challenges during those meetings. And so the final PRAPARE data was shared amongst the subcommittee, as well as our agency-wide quality improvement committee, and we also presented this data to all the community health education staff who help to administer PRAPARE. Right now, PRAPARE exists as a template in the electronic health medical record system, but we don't have a good way of pulling the data out because it doesn't exist yet in our report server. So we're hoping to work with our IT department to figure out a way so that we can pull the data out and review the data more regularly.
So some of the lessons learned through this process is that ultimately we cannot set anything in stone, that we have to be flexible and willing to modify workflows as we go, because as we go we learned and we need to make changes as needed. Some staff, we also learned when we first implemented PRAPARE, we had an equal goal among all of our staff who work in the various programs. But what we learned is that it's not realistic for all staff to have the same goals, given that they work in different settings, different clinics, different projects. So we need to tailor that goal, keeping those factors in consideration. Also, we can do a better job at promoting PRAPARE within our waiting room areas. For example, actually, Selena helped us create the flyer that you see on your screen, which we are planning to make into a poster so that it can be visible within the clinic, and that way patients know that this is something that we're implementing at La Clinica, and hopefully feel more comfortable when answering the questions or when we contact them over the phone. Also, we learned that it would be really important to recruit a provider champion within the clinical team who can also help us engage other staff in the clinical team to, in the future, extend our data collection in other departments at La Clinica besides within the community health education team. So some of the impacts of the implementation of PRAPARE is that it allowed us to have a better understanding about the patient needs, and also motivated us to recruit 2 interns who are pretty close to finalizing a resource directory that is going to be posted on our intranet, and it's going to be accessible to all of our staff at La Clinica. For our the 3 counties in which La Clinica is located, for Alameda, Contra Costa, and Solano. And we're planning to launch that in early January. We're working with our IT department to have it ready by early January. So we're very excited about that project. And we also are looking forward to implementing the second phase of PRAPARE in Contra Costa County in particular, which is also planned to happen starting in February to June of next year. And the workflows that we developed and the work that have been done are going to be instrumental to help us implement the second phase. So our goal under future plans, like I mentioned, in our next phase, our goal is to have collect 500 surveys, and at least out of those, 250 will be patients from the Contra Costa Cares that are beneficiaries of the Contra Costa Cares program, and 250 will be of the general patient population. We expect to share data findings with stakeholders in Contra Costa County and continue to build partnerships while continuing to update and expand our resource directory, and to something that we can do more and also would like to pilot is being able to track the referrals that we have done through our community health educators or our clinical health educators or our case managers, so that we could also measure the impact of the referral work at La Clínica, and ultimately identify future funding to sustain our social determinants of health data collection process. And with that, I want to thank you for your attention, and we'll be here at the end for questions.
Great, thank you. Corinne, it's all you.
Hi everyone, this is Corinne from La Maestra Community Health Centers, and I just wanted to give you a brief description about our health center. We have 5 sites in Central, East, and South San Diego County. We served 44,661 patients in 2016. Our demographics of our patients are 57% Hispanic, 6% Asian, 11% African American, 24% Caucasian, and then 2% of our patients are unreported. I'm just going to hop right into our PRAPARE. So we did our PRAPARE template, and we're very happy to be part of the pilot program. During the time period, we saw 235 patients. Currently, we just pulled an SSRS report yesterday, and we now have 458 unduplicated patients that have used PRAPARE. Our workflow, we initially wanted to use that just in our health education visits and during the initial assessment for our CPSP visit. We did find that we needed, in order to try to get to the 400 participants for this pilot, we did have to expand that out. So we expanded it out to all of our health ed sites at our 5 clinics. And our template was filled out by our health education staff. Our staff sit with the patient and ask the questions, and then the PRAPARE questionnaire, and then the staff put that into our EHR, which the EHR that we're using is NextGen. We did try to use the paper forms, and we just found that it was a lot more positive experience when we were sitting with the patient, but we are hoping to move into using tablets, actually, an MTS tablet, which it is in 4 different languages. And we're hoping that just having one staff to kind of monitor will be beneficial in the future. So some of our things that we saw initially were that having that patient concierge is what we're calling will be really helpful as we move into the MTS tablets. And some of the funding needs would be for that patient concierge staff member, as well as a private area, and so that the patient concierge could talk with the patients that need additional help and aren't able to just click through on the tablet, and that they could discuss the questions in a confidential area. So we're looking at building dividers and other things like that. we chose the health education staff because of their experience addressing and referring to on-site upstream social services, and basically the time allowed during the CPSC initial assessment. And then as we're moving into having all of our patients take this, we're really working on kind of modifying the template to allow for that. So the response to the identified needs was basically we're able to, we found out that because we provide lots of social services on site, we actually have a lawyer that is hired and on site, and she provides immigration services. We have a food pantry on site. We did find from a patient survey, though, that a lot of our patients weren't aware of all of our upstream social services. So really needing to do more marketing for our on-site social services. As I say here, you know, we have a food pantry, we have sundries in our HCH clinic site, we have our legal advocacy, job training, and we also have transitional housing. Currently we have 6 transitional housing beds, and we're looking to expand that to 14 by the end of the year. We're really using PRAPARE to improve our housing referral process and to really further partnerships with Catholic Charities, PATH, and also to work with 211 here and to participate in the Community Information Exchange, which is a local San Diego exchange, and working with these partner agencies. So some of the highlights of our interesting results, we found that housing, the question was actually did not have access to housing. That was 6.8%. And then we used actually the older version of PRAPARE. So one of the other questions was mortgage rent was an unmet need. So that was 5.9%. So we included that in the housing, which I think those were combined for the later version of PRAPARE. We found that utilities was a high need at 12% of our population, health insurance 9%, access to food, which the 7% seemed extremely high to us, especially because we have an on-site food pantry. We partner with Feeding America and our San Diego Food Bank to purchase that food and have it for our patients. And then medical care, also surprising, 6%, and access to clothing. The results of this actually needing clothing actually prompted us to set up a donation center in our Healthcare for the Homeless clinic, and to have detergent, hand sanitizer, gently used clothing available for our homeless population. So that was a result that just came out of using PRAPARE. We also found that 46% of our patients were unemployed. Of that 46%, 40% were unemployed and seeking work, and 5.5% were unemployed and not seeking work. 30% of our patients were working, and then 24% actually skipped this question. Another interesting fact was that 16% of our PRAPARE patients were veterans. We found that this was much larger than our general population, and that's something that we're looking into more, how we can better serve our veterans, especially our homeless veterans. So our insights and lessons learned, the health ed staff were the perfect place to pilot this program. They were very experienced, and there wasn't a lot of training needed for them to go through the PRAPARE template. They were really used to asking these questions as part of the initial assessment. But then when we expanded it out to, and we see when we expand it out in the future, which we're piloting it, that we will need to train, especially our patient concierge staff or other support staff that may be not as familiar asking these in-depth and personal questions. So having a staff member sit with the patient really helped. It helped and we're hoping to have at least one support staff at each clinic when we move to these tablets. And we've been downloading the monthly, or we're hoping to download the PRAPARE data monthly. Right now, as I said, we do use NextGen. We did build a separate SSRS report with our EHR vendor, TempDev, and we're looking to easily pull that data each month and just have that be as part of our monthly QI meetings. We also found that ensuring our referrals to our on-site services and tracking those referrals and closing the loop in NextGen was a big need for us, and that's something that the PRAPARE template really helped us see, and now we're moving forward to address that. We also are developing one pager on PRAPARE. We developed a flyer, but we want to develop this as part of the patient registration packets, and include that with every new patient registration, and as soon as we have the MTS tablets, have the PRAPARE as part of the new patient registration. So the impact that we had on, or the impact that PRAPARE had was, as La Clinica has mentioned, you know, we're similar in that we've been doing social determinants of health work for decades. But we don't really have good data yet, and PRAPARE is really going to allow us to have that apples-to-apples data that will really help us to move forward. PRAPARE really helped us to identify that we needed to ensure and improve our marketing plan and our marketing efforts of our on-site upstream social services, and that was sort of a missed opportunity when our providers aren't referring to the food pantry that's downstairs, or the legal advocacy that's on site and just a few houses away from our main clinic site. So improving that tracking is something that we're really looking forward, and basically using this data for our grants and individual fundraising efforts. That's something that we really see we can use in the future. PRAPARE was a catalyst for a partnership and moving forward with a partnership with a community information exchange system, and we're hoping that that will be another layer to help track the referrals with Catholic charities and PATH services that also provide housing. And PRAPARE really just allowed our staff to feel empowered and to break down silos and to be able to have those referrals go to the food pantry or go to our mental health system, or our mental health services, and just to basically break down those silos that are sometimes created. So staff are able to make referrals in EHR, and now it's useful that they're able to see the social determinants of health data as part of the PRAPARE. And with this new SSRS report, as I said, hopefully we're able to share that and see that at a high level and share it with the executive team each month. So we wanted to say thank you so much to Blue Shield and to APCHOA and NAC and CPCA for letting us be part of this pilot, and also our local consortia health quality partners. We're going to be using the PRAPARE data that we have for future grants and future fundraising, additional partnerships with housing here in San Diego, and working to open up an additional food pantry site. We actually are thinking that as soon as we roll this out to all clinic sites, we want to validate that possibly a new food pantry site would be a good investment in one of our other clinics. So we are hoping to use that monthly data as part of our QI meeting starting January 1st. And we really want to use this data to present it to our executive team and board meetings each month, and then in future strategic planning efforts for social determinants of health, and basically to make sure that our patients are getting what we call as our circle of care services, the full access to social services. That's been an important and guiding principle for La Maestra since the very beginning. So thank you so much. And we'll be here for questions at the end, or I'll be here for questions at the end.
Great. Thank you so much. Corinne, excuse me. Val, it's on to you.
Great. Thank you, Michelle. Let's see. There we go. Okay, I will try to keep my comments fairly brief. I know we're getting close to the end of the hour, but I just wanted to talk about how we can work together with our regional associations and health centers and Blue Shield of California Foundation and NAC to help bring PRAPARE to scale in California. So I just want to anchor my comments in our newly adopted strategic plan because I think it really underscores how important this work is to CPCA, and of course how important this work is to the health of our communities because we know that many of the biggest drivers of health are really beyond the scope of healthcare alone. So you see here we have a bold vision of advancing health equality for all people. So again, that really sort of sets the tone of what the next 3 years will bring for CPCA. And so what I'll do is just go through 2 out of the 4 bold steps in our strategic plan and discuss how we can integrate the PRAPARE work to leverage current and planned transformation efforts in order to bring PRAPARE to scale. So bold step 2 you can see here is called transform the health system, and many of our health centers and regional associations are very familiar with the work that we've been doing here. I just want to emphasize goals number 2 and 3 here. They focus on building and strengthening integrated delivery networks and advocating on social determinants of health issues that affect our communities. So current strategies that we're using to help bring PRAPARE to scale include, most importantly and prominently, our payment reform efforts. So many of our health centers know that we've been involved in payment reform efforts for the past 5 years. We enacted legislation in 2015 to support a payment reform pilot demonstration. And in the same year, we also launched our readiness program called the Capitation Payment Preparedness Program, or CP3. And part of those CP3 efforts have included helping to support health centers to adopt and effectively use PRAPARE as part of transformation efforts, because I think we know that you know, when we're in a value-based system, affecting the social determinants of health will profoundly have an effect on you know, on patients, and it will be demonstrated much more in a value-based system. So going forward, our hope is to significantly grow the number of health centers using PRAPARE within CP3. On the advocacy front, our advocacy efforts continue to evolve, and we are working effectively with our new affiliated advocacy organization called California Health Plus Advocates. Of course, right now, like many of you, our advocacy efforts are focusing on the funding cliff and preservation of the Medicaid program. But going forward, we hope to continue to engage with our community health centers specifically on newly formed social determinants priorities. We have started a social determinants of health peer network. So if you are not engaged in that and you are interested and you are a member of CPCA, you know, please feel free to contact me and I can certainly get you connected with that. But we're hoping that this new peer network will be an effective vehicle to uncover where we can continue to spread PRAPARE efforts and affect social determinants of health. And then the last slide, let's see here. There we go. Okay, bold step 4, promote the value of community health centers. Real quick here, I again want to point out goals 2 and 3 and how they can support the PRAPARE spread efforts. I want to underscore developing and sharing a value vision that shows how important health centers are in affecting population health and social determinants of health. And the other factors, number 3, that community health centers really need the skills and resources to forge the partnerships to really address what these issues are. So specific strategies here include creating linkages between different regional efforts for the purposes of learning and advancing best practices. So CPCA is in a unique position to really have kind of an overview of the state and see where there are pockets of best practices, and then link different efforts or different regional efforts across the state to each other for the purposes of learning. Another effort that we're doing is that we are doing more connecting with other statewide associations that are actually related to social determinants of health. So we're doing more to partner with the WIC Association and transportation groups, housing coalitions, et cetera, to facilitate these better partnerships at the statewide level with the hope that these would then open more doors at both the regional and the local levels. And then lastly, we are just continuing to explore areas for partnership with other related efforts in California, such as the California Accountable Communities for Health Initiative, supported also by Blue Shield of California Foundation, whole person care pilots, Section 2703 health homes for patients with complex needs. All of those efforts are definitely areas for opportunity where we can continue the spread efforts. So I'll just leave my comments there so that we have time for questions.
Thank you so much, Val, and thank you so much to all of our speakers. We only have a few minutes left, and for many of you who've put some questions in our chat or Q&A, we've been responding to many. And we will be able to, if we don't get to all of them, we can quickly put together a Q&A as we post the slides and answer them there. But why don't we spend the next few minutes answering some of the questions that have been posted among the speakers. Before I do, though, I just want to remind folks that attendees to today's webinar will receive a link to a webinar evaluation. I promise it is very, very, very short, and it is very, very, very helpful when you complete it. So we do ask you to respond to that as soon as possible, and thank you very much in advance. So let's quickly go to our questions. So we had a couple questions about referral and sharing data. So our first question to our speakers is, what type of data are you sharing with your social service providers through the referral process, and how are you sharing that data? So Corinne, Maria, and Selena, your lines should be unmuted.
Sorry, Michelle, can you just repeat that one more time? I apologize.
Sure. It's actually the last question listed. What type of data are you sharing with your social service providers, and how are you sharing the data?
So this is Corinne from La Maestra. Right now, our only we're not sharing it externally because all of our social services are on-site, basically. So we're sharing the data of referrals with our food pantry and with our legal advocacy and with our housing. And we're actually showing them our PRAPARE numbers and our percentages and the number of patients, and trying to close that loop in our internal referrals. So we're not sharing it externally, or we're not sharing it with any of our partner agencies yet. We just haven't got to that stage yet. Is that what was that your question? Sorry.
I think so. Thank you so much.
Okay.
Let me turn to Maria and Selena. What has been the La Clinica experience?
Selena, you want to take the lead on that one?
Sure. So right now, we haven't really been sharing the data externally like Corinne's experience. I mean, we hope to do so in the future with our consortia partners and other relevant stakeholders in Contra Costa County as part of the next project that we're working on. But to date, we haven't really shared any of the data with anyone externally.
Great. And as we said early on in the webinar, this is still a pretty new process, but I do think the desire for health centers and us at the national level is to make it possible to make it easier to exchange the data among providers and how community service providers as well. And how do we really track whether referral loop is closed. So I think that's something for future work of PRAPARE that we hope to be working on nationally, and we really will be drawing very heavily from the early experiences of PRAPARE pioneers. So unfortunately, we don't have any more time today, but we thank everyone for your participation in joining us. I also want to thank all of our speakers to today's webinars and remind folks that we will be sharing slides, we will be sharing the evaluation link, and we will find a way to answer the additional questions that were posted on our Q&A if they had not already been answered. Thank you again, everyone, and feel free to reach out if anyone has any questions.